Survival Medicine, Episode 15, Soft Tissue Infections. This one is personal. Alright, I'm going to show you some images. Some of them may be kind of nasty to some people, so just this is fair warning. If you got a sensitive stomach, this one may not be the one for you. Alright, we're going to talk about soft tissue infections. Now, there's several different classifications. You can have folliculitis, which is some infected hair follicles. Impetigo, if you've got kids, you know what this is like. Cellulitis, which is a skin infection, and abscess, which is, I think, self-explanatory. We'll go into details of each one of those. And then I'm going to mention these last two, the ones in red, gangrene and necrotizing fasciitis. Now, I'm going to show you a couple quick pictures so you know what it looks like. But I'm not going to spend a lot of time talking about these because if you get either gangrene or necrotizing fasciitis and you don't have advanced medical facilities, it's time for your last will and testament. You need aggressive IV antibiotics, fluid resuscitation, emergent surgery. These are life-threatening infections that even with the best of treatment don't turn out all that well. So what is gangrene? Basically, this looks like, zombie flesh. This is the rotting off. It can either be dry or wet, depending on what causes it. Here's an example of a foot with dry gangrene. Necrotizing fasciitis is a rapidly progressing skin infection that's just underneath the surface. If you see these blisters that are blood-filled sacs, that is a bad sign. That's something that you need to worry about. Necrotizing fasciitis can be very painful even before there's much findings on the skin. Here's another example of necrotizing fasciitis on the back of somebody's leg. This probably will not turn out well for them. So anyways, if you have gangrene or necrotizing fasciitis, you better get to some advanced medical care pretty quick. Alright, what causes typical soft tissue infections? Staph and strep. Those are the main two. There's some other things that cause it, but we're going to concentrate most of our time and effort on the things that are most common that we can try and guess at without a lot of advanced testing. If you're diabetic, you have to worry about anaerobes and other types of multimicrobial infections. Clostridium is the one that causes gangrene, and Pseudomonas is an infection that if you step on a nail, it goes through the sole of your shoe and into your foot. You have to worry about Pseudomonas being the source of the infection. All right, folliculitis. This is just an infected hair follicle. You can see a picture here. This is again staph and group A strep. Impetigo, same staph and strep, and this has that yellow honey crusts that is the classic finding. You need to get those yellow crusts off by scrubbing them, clean the area, so get them off, keep the skin clean, frequent washings, and you can use topical antibiotics or honey to the affected areas. Now, some people will use oral antibiotics, but there hasn't really been any data showing that oral antibiotics is more beneficial than just topical antibiotics for most of these infections. Now, if it's a massive infection, you'd probably want to add some additional treatment with oral antibiotics. But most of the time, just scrubbing the crust off and using topical antibiotics will work. Cellulitis, again, staph and strep, infection of the skin and just underneath the skin. This may also have an abscess with it, but frequently it can just be the skin infection without abscess. Here's an example of an abscess that you can see the pointing where the pus is coming to a head. Staph and strep are the two that we're going to worry about. So what antibiotics do we use to kill strep? This is group A beta hemolytic strep, the same one that causes strep throat. Lots of things kill this: penicillin, erythromycin, azithromycin, clenda, doxy. The ones in green are the ones that overlap with staph treatment that I'll show you on the next slide. But the nice thing about strep is that it's easy to kill. Lots of drugs kill this one. Staph is a little trickier. We now have what's called methicillin-resistant Staph aureus. This means it's resistant to our typical penicillins, so we've had to move to new drugs. Clindamycin now is sort of the first go-to drug for soft tissue infection treatments. You can use doxycycline, but that's really not going to be your first line choice. This is something that I would only use if I really didn't have a better option. The trimethoprim sulfamethoxazole is also known as Bactrim. A very good drug for treating MRSA. It's cheap, it's easy to use, but it doesn't cover strep. So if you're pretty certain that it's just an abscess with MRSA, you could try the trimethoprim sulfamethoxazole. But if you're worried it could also be strep, then you may want to use one of these other drugs. Rifampin, that's an older drug. If you take this one, it'll turn your pee orange, so don't freak out. And there's a lot of drug-drug interactions. So if you're going to use rifampin, before you do, you better check a list of drug-drug interactions. And again, here's my caveat. This is not to substitute for proper medical help. This is only for dire emergencies when you have no other access to healthcare. There's a new drug called linezolid that can be used for treating MRSA as well, but this will not cover strep. Now the next couple slides are going to be taken from the CDC. If you want to get this same flow chart, here's the URL. I'll put this in the notes as well. So this is probably going to be a little hard to read on YouTube with the small print, but basically if you have signs of skin infection which include redness, swelling, warmth, pain and tenderness, and a lot of people think that it's a spider bite. It's not a spider bite. This is going to be MRSA infection. Those are signs of skin infection. Now, are you worried about an abscess? An abscess is going to be fluctuance, meaning you feel the skin and you feel a fluid-filled sac underneath the skin. That's called fluctuance. If there's a yellow or white center, or if it's coming to a head, if it's draining pus, that's probably a very good indicator that there's an abscess there. So if you do have skin infection but no signs of abscess, then treat with antibiotics. If you do have a skin infection and there is a sign of abscess, then you must drain the lesion. Antibiotics, again, we've covered these already. It's clindamycin, the tetracyclines like doxy or minocycline, the trimethoprim sulfamethoxazole, rifampin, and linezolid. So you can just go back a couple slides to get the doses. Get those medications in a little bit bigger print to see. Now, clindamycin, and all these typically are a 5 to 7 day treatment. I typically like to use shorter antibiotic treatments so you don't get some of the other complications, but you want to use some clinical judgment depending on how the wound is healing or how the infection is healing, on how long you want to treat. The adult dose is 150 to 450 milligrams by mouth every 6 hours. Kids, you have to do a calculation. It's 3.33 to 10 milligrams per kilogram by mouth every 8 hours. Now, if they're less than 10 kilograms, then your dose is 37.5 milligrams 3 times a day. If you don't remember, you take the number of pounds and divide by 2.2, and that will give you the number of kilograms. Don't use clindamycin if you're allergic to it, and if you have underlying ulcerative colitis or pseudomembranous colitis or regional enteritis, you want to avoid these. Rifampin is a 5-day treatment, 300 milligrams by mouth twice a day for adults, or 5 to 10 milligrams per kilogram every 12 hours for kids. Your maximum dose per day is 600 milligrams, so don't take more than that. And again, if you've got hypersensitivity to rifampin, don't use it, and check drug-drug interactions. That's always a good idea before you take a new medicine. The trimethoprim sulfamethoxazole or Bactrim, the tablets typically come in what's called a DS strength or double strength. All the doses here are based off of the trimethoprim. So you take 160 milligrams by mouth every 12 hours. Or kids, if they're less than 40 kilograms, you calculate it at 4 milligrams per kilogram every 12 hours. If they're over 40 kilograms, then you just give them the adult dose. This inhibits folate use. So if you're pregnant and you need folate for DNA synthesis, don't take this drug. And if you have severe kidney disease or kidney impairment, you want to avoid this one as well. Doxy, I love Doxy. It treats a lot of different things. Not your first choice for staff, though. The adult dose is 100 milligrams every 12 hours. And the kids greater than 8 years of age, 2.2 milligrams per kilogram every 12 hours. Now, here's a picture of an abscess before and after. All pus must drain. You can give antibiotics all day long and it's not going to make this better until the pus gets out. After you drain the pus, some people will put packing in, but packing may not be necessary. And sometimes the use of packing only increases pain but doesn't improve healing. And you'll hear people talk about irrigating the abscess cavity with sterile saline. Again, that's not always necessary. And here's a link to a video that shows detailed steps on how to do an incision and drainage of abscess. If you saw the earlier video about where there is no doctor, there's a page on boils and abscesses. You can use hot compresses over the area to try and get it to come to a head. But draining the abscess is fundamental and key. Alright, thanks for watching this segment. The next couple things we'll put forth is the personal issue. I've treated hundreds, if not thousands, of cases of cellulitis and abscesses. But just recently, we got to experience this with my own son. So he volunteered himself for some pictures so you can kind of see how this developed. And we'll kind of walk you through it. Started off with just a cellulitis. He started on Bactrim, continued to progress. We had to add clindamycin. It eventually declared itself as an abscess and required incision and drainage. And thankfully, he is all better now, but it was a little bit of an experience. Alright, here's an example of cellulitis. This area that was traced was yesterday, so we were just trying to decide whether it was inflammation or infection. Now you can see in the middle part, there's a what we call pointing, which is that little red dot, and there's some firmness underneath it that's tender. And then the redness is spreading around our circle. So this needs antibiotics. We're going to presume that this is MRSA, and we need to give Bactrim or clindamycin. Alright, so here's day 2. After a single dose of Bactrim, you can already see the redness receding back from the outer circle to the inner circle. There's still a tender knot right in the middle that we're going to look at tonight and see if we need to aspirate and get pus out of that. We're not sure yet. Alright. We're getting something out of it. Trying to get it to drain, which is key. You got to get it to drain, otherwise these things don't get better. A second.
Okay. Don't move your hands.
So I'm going to come just underneath the skin.
Okay, don't move your hands.
Ow.
If it hurts, just tell us.
Ow.
Okay.
Ow. 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 Ow.
It's almost done, sweetie.
You're doing great, Matthew.
Yeah.
Okay. All right, Matt. No. No.
Very vascular, but there's still some pus in there. And it's very important that you get all the pus out, otherwise the antibiotics do not make it better. And with methicillin-resistant Staph aureus, we want to take care of it quickly. Still doing okay?
What?
Alright, here is several days after the incision and drainage. There's some redness where there's reaction to the bandage, but it looks fantastic. So incision and drainage plus antibiotics has made all the difference.